So thank you everyone for joining us tonight for our WCVIS post-match panel for 2026, part of the VIR match series. My name is Danusha Wanirachige. I'm the M3 from New York Medical College, and I'll be moderating tonight's event. Alongside me, I want to shout out Nick Pruce and Jason Kim, who are representing WCVIS Chicago, and they'll be looking over the chat while throughout the night tonight. But before I get into it, I just really want to thank WCVI Chicago and all the stakeholders that were instrumental in planning tonight's event. Something like this doesn't happen without everyone working really diligently, and we're excited to continue, co-hosting events together and are looking forward to tonight's event. So thank you again. Okay, before I introduce our panelists for tonight, I just want to briefly go over WCVIS. So our mission statement is to develop a trainee section to educate, recruit, and connect those passionate about pursuing a 100% endovascular and interventional surgical career with comprehensive and longitudinal clinical care. The direction of VIR as a specialty will be defined by those who will not compromise in providing the best possible care to their patients. And we have sections that are made for people in all sorts of training backgrounds, from pre-medical to medical student, resident, and early career. I want to take this time to also highlight some of the ongoing projects that we have. We have things like a spreadsheet for all VIR programs. On that spreadsheet, you could find information about the PGY 2 through 4 months, the amount of, years, the amount of clinic, vascular PAD experience, neurointerventional training, amongst other things. We also have multiple series, similar to this, like the WCVIS match series that we have tonight. We have How to Crush Your Sub-I series, Acute Care series, a Unite plus WCVIS series, and the Landmark Trial series. We also have educational resources like procedure guides for Spanish-speaking patients, a robust mentorship program, upcoming podcasts on 100% VIR practices, and more things to come. We encourage everyone to stay updated. So please follow us on social media at WCVI Society on X/Twitter, Instagram, TikTok, and YouTube. You could add the Google Calendar to stay up to date on upcoming events, and that link is available at the website under the Events tab. And please check out our website at wcvis.org. Lastly, for those that are interested in membership, you could become an official WCVIS member at wcvis.org/membership, or you could follow the QR code that's listed here on the screen. All right, with that, I would like to introduce our esteemed panelists for tonight. First, we have Arashleen Pannu. She's currently going to medical school at Sidney Kimmel Medical College, and she will complete her surgical intern year and VAR residency at Mount Sinai. Next, we have Selena Yao. She is going to medical school at Wright State University, Boonshoff School of Medicine, and she will complete her surgical intern year and VIR residency at UCLA. Next, we have Hossam Zaki, who he is completing his medical school at Warren Alpert School of Medicine, and he will complete his surgical intern year and VIR residency at Duke University. Next, we have Zachary Cherian. He is going to medical school at Chicago Medical School at Rosalind Franklin University, and he will complete his surgical intern year and VIR residency at Aurora St. Luke's Medical Center in Milwaukee, Wisconsin. And lastly, we have Abinaya Ramakrishnan. She is completing her medical school at UCLA David Geffen School of Medicine, and she will complete her surgical intern year and VIR residency at surgical intern year at Swedish Medical Center and VIR residency at University of Washington. All right. Sorry, let me stop share. Okay, so thank you all for taking the time tonight to speak with us. I think a great way to get started off is if we could go around and just have everyone briefly introduce introduce yourself and what drove you to pursue VIR. And Abinaya, why don't you start, if that's okay?
Sure, yeah. Thank you all so much for being here. WCVIS has been like my baby for the last 4 years. So I'm really happy to kind of do this culmination of my 4 years of med school. I think what really got me into VIR was a big push towards surgery. I came into medical school thinking I was going to be a surgeon. I watched a lot of Grey's Anatomy growing up. I still keep up with it, which is my fun fact. And I really thought I would be like Christina Yang and be this cardiothoracic surgeon. And I came into med school really gung-ho about surgery. I shadowed a lot of trauma surgery, a lot of cardiothoracic surgery. But somewhere in the middle of it, I realized that I really enjoyed a lot of medicine for what medicine is. I wanted to do something that impacted all the different organ systems where no 2 days looked the same. Maybe it was my immaturity, but I felt like cardiothoracic surgery had a lot of repetition. They were doing a lot of cabbages, a lot of TAVRs, and it felt very repetitive to me as an early medical student. And I wanted something that had a lot more variety to it. I'm someone who gets bored. Like I can't even eat the same thing for lunch and dinner, let alone do the same thing multiple times a week. So to me, I wanted something that was exciting where I could work with adults and kids. I can do trauma, I can do non-trauma, I can have quiet days, I can do outpatient work, I can do heavy inpatient, I can work in a rural community. And really, it just gave me the opportunity to see a different perspective of surgery while doing more minimally invasive care. And I love the innovation aspect for it. Like I think all of us here have been very involved in VIR from a very early point in medical school. And for example, when I first went to guest as an MS1, like prostate artery embolization was just up and coming. Like it was maybe one or two talks. And last year when I went back to guest, it was like half a day was dedicated to prostate artery embolization. So I do think that our field is very rapidly changing. And I love that aspect to it, that what I trained during residency is like probably not what I'm going to be doing 10, 15 years down the line.
Yeah, Arashleen, you want to go next? Oh, thank you.
I can go next, yeah. Hi everyone, I'm Arashleen. For me, I think I came into medical school very open, knew I was more procedurally oriented. I think there are two sides of me, one that's incredibly service oriented. It's a lot of what I pursued in my extracurriculars, and then the other side of me is very procedurally and engineering minded. It's how I was raised, how I grew up. And so I think coming into medical school, I honestly found VIR just because of happenstance. I think that's a lot of us. I went to a mentorship dinner for free food, and then ended up meeting these wonderful attendings and ended up shadowing a lot. And I think ultimately was still very open. I was interested in OB surgery and ended up really loving surgery. Ultimately, though, I rotated on vascular surgery where I was really able to go to clinic and compare the open and endovascular approaches to aortic and peripheral arterial disease. And for me, I think what I really understood in clinic was that oftentimes patients really did prefer an endovascular approach, and that the even if, for example, this is just one example of many in VIR, but even if you can delay an amputation by a year or 2 years, that's really purpose-driven care and very mission-driven care. And so, and even that makes a huge difference in a patient's life and their autonomy. And I think for me, VIR was a method to really honor a patient's purpose and autonomy through minimally invasive care. And before even, because you can always escalate up to an open approach or surgical approach, right? So for me, I think it really spoke to the service side of me, and the innovative and engineering side of me really brought those two sides together. And ultimately, that's why I ended up pursuing it after rotating on vascular surgery. So if you can rotate on vascular, do it. I did it for 6 weeks, and I think it really changed the way I thought.
I'm happy to go next. My name's Hossam. I'm a fourth year at Brown, and I actually came into med school thinking I wanted to do it's like a pediatric genetics because I was really interested in genetics in undergrad, and I felt like it would be a great way to, try and help some kids. But what I realized was I wanted to have some more patient impact, and because I studied computer science in undergrad, I knew that like diagnostic radiology was a thing, but to me, diagnostic radiology wasn't really for me. I wanted more patient interaction, and I wanted to be able to like directly impact the patient's care with my own hands. So, I went to SIR my first year because I was lucky enough to get onto an abstract, and that's kind of how I got introduced to IR. But I went into third year really with an open mind. And I did a 2 week rotation on vascular surgery, and I had done IR before then and got really close to a couple of the surgeons. They let me like become first assist on a bunch of their endo cases because I knew how to fold the wire. And that like really made me really interested in vascular surgery for a minute. But what I think drew me to IR in the end, I was between vascular surgery, IC, and IR, was that we get to become masters of all of the organ systems, from the brain to the legs, the liver, the kidneys. Like you understand everything. You can speak the language of all of these consultants. You can speak with a nephrologist, you can speak with a clinical care doctor, and you understand their language. And I think, we're really like the last line of resort for a lot of patients. Like Arashleen said, like if you can delay an amputation, you're gonna have like a really um really profound impact on this patient's life. So I think IR can have a massive impact on patients, whether, postpartum hemorrhage, you can save a life after this woman has given birth, or, this patient has like urosepsis and you can just place a PCN. I think, more ways than one, you can really have an impact on a patient's life in IR. So that's why I ended up doing it.
Yeah, and I can go next. So my name is Zach. I'm a fourth year at the Chicago Med School. And similar to a lot of things that we heard about, I started med school pretty open. I was actually pretty gung-ho about emergency med for a long time. But then I quickly realized it's not like the shows that much, but the pit is getting really close. Um, but still, I really liked the pathology, the acuity that you get in EM. So kind of along the way, I was exploring so many different specialties. Similar to Hossam, I liked DR for a little bit. But it was really lacking that patient-facing interaction. And then after my surgery rotation, I knew I had to do something procedural, hands-on. So I kind of thought to myself, how do I correlate all this? And huge shout out to the IR faculty advisor, Dr. Shamit Desai, who's also the faculty advisor for WCVIS Chicago. He kind of gave a presentation that introduced me to the field of IR. And that was, it just blew my mind from then on. I haven't looked back since. Kind of similar to what Abinaya was mentioning earlier, is even though I really love surgery and I was kind of struggling, how do I decide between surgery and IR? It's a really historical field, surgery, where there's a ton of repetition going on. There's not so much of an innovation. It's really if it ain't broke, don't fix it type of system. Whereas IR, it's a constant system of innovation and improvement. We're always trying to push the boundaries. And, I'm of the belief that one day I do believe that IR and interventional surgery itself will replace all types of open surgery. Just as technology, as imaging, as we get better and better at detecting things earlier, I think that IR is the future. And that's really what excited me the most when I was trying to determine what specialty I want to go into, is what will be the future of medicine itself. And for me, the only answer to that is IR.
Right. I guess I'll finish us out. So a lot of what everyone else has said, I echo a lot of that sentiment. I am a little bit of an ugly stepchild though, right here, because I went into medical school thinking I'd do primary care, maybe EM, but mostly primary care. When I found IR, it really spoke to a lot of experiences that I had in the past. I worked as an EMT for a really long time, and during that time, I saw how important, quality of life is in maintaining functional statuses for patients. And when I found IR, that like it blew my mind that there were these things we can treat cancer through a needle stick. I mean, we can treat postpartum hemorrhage without taking out someone's uterus, all these things that help patients live their life to the fullest because we are so minimally invasive, that we have not really learned about in medical school, especially at schools without programs in IR. And those are the things that I just like really spoke to that aspect of me. And then, of course, the innovation side, I worked in biotech, so it also kind of just like fell into what I liked and cared about before and kind of tied it up in a neat little bow. But really want to hammer in how important it is for our patients to have autonomy, how functional status is one of the most important things in patients' lives, not just living as long as they can. Of course, if that's what they want, then great. But a lot of patients don't actually want that. They want to be able to keep on living. They want to keep on walking. And some people in women's health want to have a possibility of children after a really scary experience. So all these things is so uniquely capable of doing. And that's why I decided on the field.
Wow, thank you everyone. I could just want to say I really feel the passion for the field from each one of your responses, and we all really appreciate it. So just to segue now, just to get us started tonight, many of the attendees are coming from different backgrounds. Within medical school, some are preclinical, some are clinical, like in M3 and 4 year. If just a couple of you can briefly highlight for the preclinical students that may be watching, what are some things that students can do early in medical school that could help them build a strong foundation for VIR? And anyone can take a stab at it.
I can
I'm
start us
happy to.
off.
Oh,
Oh,
go ahead,
sorry, go
Serena.
ahead. Okay. I can start us off. I think, especially if your school doesn't have a strong VIR presence already, finding a mentor, joining things like WCVIS, WCVIS Chicago are really great resources, and try to get your foot in the door and join some conferences. Even if you're not presenting, even if you're not doing anything, that's how I started out too. Getting that exposure and talking to people, meeting people, seeing what the lectures are about, that can really get you a better feel of what the field is about and what things are up and coming as well.
Yeah, I think, for me in the preclinical side, I think definitely, finding a mentor and shadowing is really important. I think there's two main things that I think we should talk about. The first thing is just to explore everything. You want to make sure if you decide to do like if you want to do VAR, you want to be pretty sure that you want to do it. You shouldn't really go into med school thinking I'm going to do this and this is what I'm going to do. Like you should definitely explore because there's plenty of, good specialties out there that, that you should explore. And I think the second thing is just, you should be able to spend time like studying medicine because the preclinical years are a great time for you to develop your foundational like medicine concepts that are translatable to literally everything. And when you go into third year on the wards and you are on your IR sub-Is, like a lot of the stuff that you learn in preclinical years come up and attendings will ask you questions or you'll see patient scenarios that like you had read about in preclinical years. And if you have that foundation that you built up in preclinical, then you'll be all set. I've seen people fall into the trap, especially for like hyper competitive specialties like derm or ortho. They're spending all their preclinical time doing research, and when it comes time for the wards or whatever, they're struggling a lot because they don't have that foundational knowledge. So they're trying to study while also being on the wards during third year. So you want to try and not fall into that trap while also, doing some extracurriculars, doing some research, but also not neglecting your studies as a med student.
I agree. That was exactly what I was gonna say, is that never like grades always come first. Not necessarily grades, but just your foundation always comes first, because that's one thing that no one can argue with you about. Same with, I'm just a big believer in when you're creating an application, there's a lot of gray area for a lot of things, but there's no gray area when it comes to numbers, when it comes to the objective data. So the best way that you do that is by studying, getting good grades, and making sure that, your board scores are going to be solid. They don't have to be amazing, but solid. I think the second thing is I used a lot of my preclinical time to lay the groundwork for. So I went into kind of med school knowing, okay, like what does the ERAS look like? There's 10 slots for activities, and there's three most meaningful. What are they going to be? And so I think if once you start thinking like that, it really helps you set yourself up for success. So think of the three themes you want in your application and how are they going to tie back to IR if you know that you want to pursue the field, whether it's service, whether it's research, whether it's whatever. That being said, so that means make sure you have a couple things cooking for research, make sure you have a couple things cooking in like the extracurricular situation, have one thing, but also have one thing that's like your baby. Have one thing, it doesn't even have to be VIR related. A lot of my things that were my most meaningful, not even VIR related. They were so different from the field. but they were mine. And I spent a lot of time really getting my hands dirty and making things come to fruition. And I think that is something that helped me not only perform in my interviews, but also kind of stand out. It makes you memorable. I think getting the interview is one thing. That's where like the hard numbers come in, but then actually being able to perform on the interview and make an impression is another thing. So start thinking about that a little early because once clinicals start, you get busy, you start caring about step two, and then it's time to apply, and then you're kind of scrambling for things to put on your CV. So, and also with research, the last thing I'll say is I was really nervous that I didn't have a lot of VIR research. My most involved research was like neuro chronic pain research. But then you really think about it, and because the scope and the breadth of VIR is so wide, you can relate almost any research project back to VIR. All my chronic pain research, I related it back to MSK and like kyphos and that kind of thing, right? So it's like there's a lot of scope. And if it's hard for you to find VIR research, look at your vascular surgery department and look at your neuroendovascular neurosurgeons. Look there. Yeah, that's all I have to say.
I will just add one little thing. Is mentorship, I think, is very important. Like, if you can just identify one mentor who's going to go to bat for you and all these things happened in your life during fourth year, identify one person who's going to sit with you and be honest with you about your application and who's going to go to bat for you if they need to pick up the phone and make phone calls, if they need to email people, if they need to use their network, whatever that network is, find one person at least who can really work with you to make sure you have a successful cycle.
Thank you so much. Really, really great pearls and a lot of good information there that I'm sure all the attendees will appreciate. So a lot of things that we could talk about right now, but I kind of wanted to segue to one of the bigger themes that we wanted this discussion to be about tonight, and that's understanding IR as a clinical specialty. I know this probably come up a lot in interviews and when you're on your away rotations as well, kind of gauging like if a program has like a lot of like practices a lot of clinical IR. So my question is, what does a clinically strong VIR program mean, and what does it actually look like on a day-to-day basis as a resident? Zach, if you want to, I'm just picking
Yeah.
randomly. If you want to go ahead,
Sure.
start.
I can start. Yeah, sure. So I think that kind of one of the themes when it comes to looking at what makes a good clinical VIR program is some of the stuff that we talked about earlier, right? Is how involved are they in the actual practice of medicine? Because the danger of any procedural specialty, but especially in IR that you go into, is you end up becoming, for lack of a better word, a line monkey, right? Somebody sends you an order, somebody sends you a procedure to do, they tell you to go do it, you put in a line or a drain or whatever the procedure might be, and you never touch the patient again. In some practices, you never even have to see the patient at all, actually. And so that's like, it's crazy, right, to think about. But the really big thing when you're looking for a good VIR program is how do they actually practice medicine on a day-to-day basis? How is their clinic looking like? Do they actually see patients? Do they actually block out time for residents to be able to go see patients? It's not just like an attending only run thing, right? And then even speaking to the residents themselves, how is their day-to-day practice of medicine? Do they actually want to non-interventionally manage patients, even like make recommendations with regards to their medications, make recommendations with regards to what they actually think is going on with them? Just understanding that clinical way of thinking and how the residents handle patients like that, it's really telling of how the VIR program as a whole will be. Because at the end of the day, you don't want to just be churning out procedures at the end of the day. You really want to be practicing what you trained to do, which was be a doctor, right?
I put some questions in the chat that I think are important, but one thing that I asked a lot during my interviews that gave me a lot of either comfort or not comfort based on what different programs answered is if a surgeon needed to put in a drain or they needed to do a procedure and they put in the order, what is the workflow look like on your side? Does that mean that you're immediately going to do it? Are you going to have a conversation with the surgeon? What happens if you don't want to put in the drain and that you don't think that it's appropriate for that condition? What does that collaboration and process look like? Because having done a ways at different programs, it works very differently in different hospital systems. And sometimes VIR does not have the ability to push back. If a surgeon calls and says they needed a drain, like that drain is happening, whether you in your clinical judgment think that that's right or not. And I think that's very indicative of the type of clinical reasoning that's happening from the VIR. Is it a consult or is it an order? Because if it's an order, that's a completely different workflow than if they're putting a VIR consult in.
I think also just kind of bouncing off of that, when it comes to consults, who's working at the consult? I think a lot of the times, a lot of programs tout having APPs or support staff as a plus, and it is a plus. They're wonderful to learn from, but you need to learn from them, right? So you need to take the consults, and so I think one thing that I realize on a lot of my ways is, like who's running the consult team, who's holding the pager, who's taking ownership of these consults, and who's running the board. I think that is also a good way to gauge if residents are kind of developing this skill of decision making, and if they're like put in uncomfortable decision positions where they do have to make a decision, and kind of work a consult out from scratch. So I think consults, I think, is also a very valuable thing that I considered.
Yeah, I
And just
think for me,
go.
oh, sorry. For me, like, every single program on their website will say that they are clinical, and every single program will say that they do everything. But the reality is that that's like not necessarily true. So you really get, the vibes either from residents or med students who've rotated there. So for me, when I was looking at programs and I was seeing how clinical they are, was, how often do residents go to clinic? Do residents ever go to clinic? Do they go to clinic like once a week? How often is that split? Then I would ask, like, how often is the IR resident integrated into the IR team during their DR years? Are they like never going to IR? Are they doing like a week of IR, like the same amount of their DR residents, or are they doing some more? And then I would ask, like, what's the role that IR plays in the hospital? Like, you basically want to ask the question, like, are IRs just the line monkeys and the drain lords, or do they actually do stuff? And I think you kind of like need to figure out the phrasing to ask that question of like, what is IR's role in the hospital? So it can be hard sometimes to truly figure it out unless you're like rotating there or people who have rotated there. But like Abinaya said, like there are some places where if IRs said put the drain is getting put in no matter if I don't know, the drain is in the eyeball or something. They're just gonna do it. So if there are other places where IR says like no, let's actually discuss, and they treat IR as a true consulting service. And it's hard to parse that out, but residents and people who've rotated there are your best bet.
Great. Thank you so much, everyone. That was really great points everyone made. Just for the sake of time, and before we go out into breakout rooms, I just have one more question I want to ask, specifically about the surgical preliminary year. So, most of you are, you're all going to do a surgery prelim year, either at the same institution or at a different institution. So my question more is about the logistics, and if it's okay, I'll just have Selena go ahead and answer this one. If you could walk through your approach to applying to and ranking like your preliminary programs, and like exactly like the logistics of how does this surgical preliminary program interview season, like does it conflict with the VIR program interview season, and whatever, and etc. So if you could expand on that a little bit.
Yeah, absolutely. I think I'm lucky in that UCLA is a categorical program, so I matched where I will be forever, which is great. But I can definitely answer the other questions. So in terms of the preliminary surgery intern years and how I applied, how I interviewed, I kind of did it based off of the institutions that I applied to for IR as well. So VIR, and then I kind of just looked at those institutions, see if they offered a preliminary surgery year. Didn't do all of them, but places that I kind of targeted regionally. So California, I applied to most of the surgical prelim years there. Around here, which is Ohio and the Midwest, so Chicago, I applied to a lot of the surgical prelim years there. I kind of did it based off thinking how many times do I want to move and logistics of that. I think surgery intern years everywhere will be pretty good, since surgery is, such a robust program in general, and they've had prelim years forever. Of course, once you get those interviews, then you can start being a little choosy. But that's kind of how I approached it in the beginning. And towards the end of it, is really when you start getting those surgery prelim interviews. I didn't really get that many conflicts. A lot of the prelim interviews are 15-minute chats. Some of them have you sit on for like a couple hours, but for the most part, they just schedule a specific time, and you just show up to those either by the phone or on a Zoom interview, and just go with the flow of whatever they do by that point. It's at the end of interview season. They just want to make sure you have a pulse, you're a normal person, and that you're committed to, actually being a surgical intern, not just applying to apply. And the biggest question they'll always ask is why prelim, intern, or sorry, surgical prelim year over a transitional year, which is the easy way as people see it.
Okay, great. Yeah, thank you so much. Really good information there again. Um, as mentioned in the chat by Abinaya, I think now we'll segue to go ahead and go into our breakout rooms based off the region that everyone like matched in, and you could everyone that attends can answer any questions that weren't answered like during the first half of this panel in the breakout rooms.
And then also, if you want to, feel free to move around to different breakout rooms. That's also an option. For example, I'm from the Midwest, but I am doing the West Coast because I went to med school here and I matched on the West Coast. So happy for you all to like move around and bounce around and talk to all of us. We'll plan for this for about 30 to 45 minutes, but at least I'm happy to stay over. I'm sure most of the panelists here are happy to stay a little bit over to answer some extra questions as well. Thank you all for joining us.
Hi, sorry. For the breakout rooms, is there a n northeast region? Sorry if I missed that. Okay. Um yeah, because Arashleen, I was curious, you're like what made you interested in Mount Sinai or what you particularly were drawn to with the program?
Yeah, we'll chat. Denisha, is this my breakout room or am I going somewhere? What's the vibe?
Arshleen, you're going to the one that says South and Eastern.
Love. Okay.
Yeah.
Sorry about that. Thank you.
Also signal them as well. And I did 4 away rotations, so that essentially meant that half of my signals went to making sure that my away programs were knew that I was still interested in them, having done an away and or going to do an away. And then the other programs were just ones that I felt like I needed to signal, otherwise I wouldn't get an interview at. I do think that for VIR, geographical signals play a large role. There's a lot of programs I did not personally signal and I got interviews at because they were in my geographical area. So I would really consider giving signals to programs that are not in your geographical area because otherwise they have no idea you're interested in them. I'll give you an example. I signaled Duke. I did not signal the South. I have no connections to the South. There's no reason for Duke to think that I would be interested in them had I not personally signaled that program. So I do think that signals are important, especially for programs that you have no geographical ties. So you're not going to geographically signal them, and you're not going to do an away there. Melanie, if you have anything to add.
I had like actually a kind of different experience where I got a lot of interviews like all across the country, even in places where I didn't geo signal and I didn't actually signal them. So I'm not exactly sure like what their process was for like choosing who to interview or whatever, but basically how I chose to signal was I like obviously we got 8 non-tiered signals for VIR this year. And I did aways at 4 different locations. So I also used half of my signals for the programs I did aways at. But I think what you could do is if you're doing an away at a place, you can ask them, you can reach out to the PD and say like, do you expect us to send you a signal? Or like, is it just like acknowledge that since I'm doing like a whole month here, like I'm traveling here to do a whole month at your institution, that I'm interested in coming. I was very neurotic, so I signaled even the places that said that it was fine to not signal. But I know a lot of people don't. And for the rest of the 4 places, it was like places where I wanted to go and also like geographically where I wanted. I mostly signaled like in California, and then I also signaled a couple like in the Pacific Northwest and in
Because they've, been doing it for however many years, 20 years, 30 years. But if you listen to everyone, listen to the text, listen to the nurses, the residents, and just absorb that knowledge. And when someone asks something and you don't know it, the next time they do ask, you should know it. And if you care to, join this field, then that self-drive is really important too, because people don't want to babysit. People don't want to hold your hand and spoon feed you knowledge. Look into it, and it'll help your patients in the long run too. So those are like kind of the general specific tips that I have. But the one thing that I do have is find a place to fill a gap. I think that's what I did. That's what I did with the rounding. That's what I did fielding consults. And I think that's when you can shine. Don't wait for someone to tell you to do something. If it's in your scope and if it's some way you might be able to be helpful, try it out. Don't hurt anyone, don't overstep, but people do appreciate the extra effort you can go that you put into things.
Thank you.
And then just quickly answering 2 of the questions that came up in the chat, with regards to how many aways do we recommend? And then another question was, have you done aways after the apps went out? Is there a recommendation to do this? I don't think that there's a strict number of aways you should do. People will always tell you do like whatever, 3 or 4, but you do have to keep in mind that unless your home program has an IR residency or affiliated hospital, wherever it might be, you do have to pay, right, to go through VSLO and other routes. And so you have to also account for, hey, not only have to get my applications out, which there's no guarantee that you'll get that, but then you have to consider travel, housing, food, whatever it might be. So do as many as you can possibly fit within your schedule and that you could, afford and account for with all these other expenses. But there's people who've been doing 1 or 2 and they still matched and did everything just fine. I'm not saying that that is the recommendation. The recommendation is do as many as you can, but don't stress if you haven't done like 3 or 4. And then with regards to doing away after apps went out, I think that there's still great utility even after your apps went out. I personally did an away rotation in December and January, which is like way after Eris was submitted, closer towards the end of interview season. And I already knew that, but the utility I saw in that was now you get to get more face time with a program that maybe you already interviewed at, or if you didn't get an interview from them, maybe they'll offer you one after the rotation, right? So there's still great utility that comes from that. And it keeps you kind of fresh in the program's mind, even if you already interviewed with them. So I think that there's no harm in doing a rotation even after apps are done.
Yeah, I echo both of what Zach said. Away rotations as many as you can, but again, don't stress. I mean, there's a lot of other limiting factors as well. My school limits the amount of away rotations we can do, period. It's 3, so it's a good amount, but if your school limits it to more or you can't handle it financially, or sometimes the schedule just doesn't work out because you have required things to finish too with your own institution. Don't stress out too much about that. I think in terms of getting, letters of rec, it might be helpful if you don't have a home program like I did. I relied on a couple away rotations to get one letter of rec. I have a home attending that takes on students, so he had one for me. But otherwise, getting your foot in the door is always helpful. And again, if you can do a month-long interview, that's always better than a virtual, 2, 3 hour interview. I also did an away rotation after apps went out and agree with Zach. I mean, it's just another way to um, show your best foot forward and really have them familiar with who you are. It's a lot easier to be vetted over, a month rather than a single day where you can be lying through a camera. In terms of for preclinical years and advice on getting involved in the clinical space, I might have to defer more to Zach for that since I was primary care for like a bit and then I was OB-GYN for a bit. I kind of just started my own outreach club with the goal of
Yeah, the funniest times was like I remember there was a tips and like I I I decided to go in and the tech was scrubbing in and she's like, "Oh my God, thank God." And then
Yeah.
she then she left. So yeah, that it if they trust you, then they'll be your greatest asset.
Validating
And
stamp of
yeah.
approval.
There's a
That's
question in
true.
the chat
I
of
do
like,
that.
did either of you attend SIR and how did you use that as an opportunity to learn the language and set the stage? I went to SIR. I was lucky enough to go as an M1 because I got my name on an abstract and just decided to go. And really, I think like some of the big benefits of going to SIR is especially early in med school is you kind of like get to see what IR really is. Like if your school like only does like, a couple of things, and then you go to SIR and you learn more about like, aortic stuff, PAD that your school may not do, or like you learn more about like the interventional oncology stuff, the new trials. Like it's really interesting to see what IR is doing. And I think for me, though, one of the biggest things about SIR was like, getting to meet med students, residents from all over the country, see how IR is like at their schools, and like just get their advice at different stages of med school. And sometimes like, it's a great networking spot. Like if you are looking for an away and you're a third year and you find the PD at SIR, it's a great way to try and network and try and get the away rotation. Um, so it is very valuable. And just the networking piece, like people will remember you on interviews if you said what's up to them in SIR, and so will the residents. And yeah, it is a very valuable experience to go.
Yeah. I personally, like my stuff never got accepted. So actually I didn't go to a single SIR, even though I kind of knew I wanted to do IR since day one. There's always either I wasn't dedicated or I don't know, or something didn't get accepted. So I actually didn't go. And so I think there's a flip side. I think definitely go to SIR if you can, but also if you don't go, don't stress because I was super stressed that I had never gone and I ended up fine. I think just make sure you're involved in something VIR related, make sure you have some mentors, and you'll be very fine. You absolutely don't have to go.
Yeah,
Even if you can even get yourself involved in like their student council reserves or something, that's what I ended up doing with SIR, more than enough. Or make sure you just have a couple of VIR related things. You don't need to go. Just make sure you're doing the networking if you're not going.
great.
What else?
There's another question in the chat that's what was the one specific thing on your applications that really made you stand out on interviews slash something you were really proud of? Um, I think like, I think Arashleen said something really important in the break in like the panel, which was like you should kind of go through med school and like think what are my like top three most meaningful experiences. And it's kind of like corny to like say like I kind of need to go through med school with that in mind, but like you kind of do because this it's really important and they will not read any of the other 10, or the other seven. They'll only look at the top three. So they'll ask you questions about that, and you got to make sure that like it's something that you actually meaningfully participated in, and it's something that you really like. So I got asked a lot of questions about that. I got asked questions about like some things about my research, like what was your favorite or what like which research project were you most proud of? That question came up like a million times. They would say like, um, where do you like what research project do you think like um will impact medicine the most or whatever. And then I got asked, I think 70% of my questions were asked about my hobbies. And they're like, "Oh, what do you like? What do you do for fun?" Oh, I see like I put like F1 and fishing and hiking, and they're like, "Oh, like where do you go fishing? Do you go like saltwater or freshwater?" And then they'd say, "Oh, where's your favorite place you've hiked?" 70% of my interview questions were about that. But I think like I think the actual tangible stuff that I think really makes a difference is like your top three meaningful experiences, your research, and I think step two is just like your foot in the door. And like I feel like I feel like 255 and above is probably a good cutoff, but I would lean on the side of like if like to be really sure you could just get a 260 and above, and then you're definitely good. Um, but I think step two just to get your foot in the door. Like I know people who have gone high 270s who like didn't match where they wanted to be. It's not the make or break, it's just to get your foot in the door.
Totally agree. Numbers are really only there to get your foot in the door. And then yeah, like performing on the interview is super important. I think for me, I think a couple things like, I think made the difference for me. One was I think mindfully crafting your application is so important. Like have at least two themes. So one of mine was service and one of my yeah, service education and then like innovation was one of mine. And so I think finding a way to compile your 10 things plus your research into maybe two or three different themes, weave them together into your story, make sure they're in your personal statement, make sure you connect them back to VIR, the kind of VIR you're going to be in the future, how it's going to impact how you practice VIR, and how are you going to kind of bring that to their residency. I think just having that good follow through with your themes is so important. I think it was what made me stand out. I think it was commented on a couple of times because it's in my personal statement. I think humans respond to human things, and so I think everyone has their own approach, but I really tried to humanize my application. Um, and I think people really responded to that. And also I think letters are also really important. Make sure you have at least one letter where the person really knows you, has worked with you a lot, and can really vouch for you. Yeah, and I think having again, VIR is a field where it's really hard to get exposure to medical students. So if you have like two or three things on your application that are VIR oriented, I think even that is impressive, and they will ask you to speak on it. So really do that. And really, honestly, more than anything, be able to speak about IR meaningfully, not just like, oh, I love minimally invasive or I love innovation. If they're asking you, what was your favorite case? How, like, pick a case where maybe it's not like the coolest case you've ever done, but it made an impact on you because XYZ. Really be able to say something profound about it. Either know the management really well, know the nuances. I think nuance is everything. Really know the nuances. That just makes you more impressive. Yeah.
Yeah. So the next question was, uh, what was your typical schedule on aways and what were your responsibilities? I think, the schedule is so different across different institutions. Like, for example, at Brown, my home institution, like we would run the board at like 7:30, and then so we'd run the board at 7:30. We would go over some of the cases like separately, look at the imaging, and then we would have cases from like 8 to 4, and then you as a med student, your responsibilities would be like you present like a case for the day, you talk about the imaging, you talk about the indications, whatever, and then you go to the different cases and you back table. So in the back tabling, you're basically like, for lack of a better word, you're kind of like glorified scrub nurse. You do like you prep all the stuff, but I think the point where you can take it to the higher level is anticipating what they may need for the next step. Like if you've seen a port a million times, like then you should know like, okay, like after they put the like the micro dilator and sheath, then you give them the J wire, and then they're gonna measure it. So make sure you have the ruler ready and all these things. So like, make you should just anticipate the next step. That just takes it to the next level. At other places, like for example, at Duke, where I did an away rotation, they would round on their on their service at like 7 a.m. and then they would go over the cases later. So my responsibilities there would be I would round on the patient that I did a procedure on the previous day. I would talk about whatever, see how they're doing, talk to the primary team, all these things. And then we would also present the case. So, um, and then same thing, then you go in and you back table, and sometimes you would do consults and during the day. And yeah, it would vary a lot, really depending on the service. But I think the primary responsibilities are rounding, seeing consults, and back tabling.
Totally agree. I think some of like the biggest advice that I would give on my away rotations that I kind of learned as I went through is like your first rotation is always just going to be your worst one because you have no idea what's going on. But still, it doesn't mean you can't perform well. I think, yeah, learning to anticipate the next step, and honestly try and hand things to your resident or your fellow or your attending before they even think they need it. I think, there's just and do it without thinking, like put things to the side and work on the next step. Like I think showing that you can multitask and learn, even if it means like take a wire home, take a catheter home, and practice rolling it up, like practice even like trying to pinch and pull. It's really important that you have those skills, then you can take yourself to the next level, because if you're too busy trying to like fumbling with the wire, you're never going to get to the next step. I fumbled all the time on my first rotation, and then I got better, but that's why doing so many rotations is a good thing. And then I think the other thing is a lot of some away rotations are very structured. For example, I rotated at Kaiser and the structure was immaculate. You knew exactly what you were going to do. You're going to round in the morning, you were going to go scrub a case. After you scrub the case, you were going to write the procedure note. And then one week you were on consults, like you knew you were going to write the note, you were going to see, you were going to present, you're going to clinic on Friday. And I think when there's that structure, you know exactly what you need to do. You have jobs. So it's good. It's really easy to get good at something and to show what you know. There are some rotations that are not as well structured. It's just, yeah, show up, scrub whatever case you want to scrub, whatever, you're here to learn. And it almost turns into an observership. And I think that's a very, very dangerous hole to fall down. Because then if you're just standing there observing because you weren't given a job, then how are they going to know what you know and what you don't know? So I think it's a really delicate balance in being a little aggressive, and not stepping on people's toes. So that means, of course, asserting yourself in the room and asking the scrub tech, oh, is it okay if I do this? And kind of working your way up to more responsibility. It also means asking insightful questions at the right times in the room to show that you have knowledge, and also understanding different ways to treat things. Because then when something goes wrong in a case, you can say, oh, like what if we tried this? And I think that shows another level of knowledge. And then another thing is when downtime in between cases. If there's another resident on consults, you may not have been told like, yeah, you're able to write notes for the residents, or you're able to go see a consult, but make the work for yourself. If you're sitting there doing nothing and you see like your residents kind of drowning in notes or something, say, oh, is it okay?
Is also helping out with consults. I was going to type it in the chat, but um, most programs will let you as a med student kind of go and see a consult. I think that's another great way to like show your clinical skills, your thinking. At WashU, where I did an away rotation, which I highly recommend, probably my most favorite rotation of all of med school. They like let me they had a board and you can put your initials next to any consults that you wanted to see. So at the beginning, I was mostly just seeing people that needed dialysis or like needed a line or whatever. And I would go and see them. I'd work them up. I'd see indications, their labs, make sure that they were all teed up. And sometimes I would even go and like pre-consent them and give them the whole consent speech so that literally they would come down, they knew what they were getting, they would sign the form, and it would make the day run a lot smoother. And then as you like progress through your weeks, you can start taking more important consults. I think my last week I took a trauma. So I think the smaller things that you do and you do a good job, it'll make people more reliable to give you more tasks. I think another thing is also being comfortable saying like, I don't know how to do that. At UCLA, our PD is very famous for asking you a question. And then oftentimes as med students, it's very easy for us to like kind of like flounder up an answer. And he really wants to see people who will be like, I actually don't know. Like, let me look that up and come and get back to you. Like, I think that's a really important skill to have because you need to know what your limits are because that's a safety concern as a program director is like, are you going to say that you know how to do something that you don't actually know how to do or don't feel comfortable doing? And are you okay understanding your own limitations and going, looking it up, practicing, getting your answers from whatever it is, and then coming back and showing them that you've put in that time to understand your limitation and try to get to the next level. And yeah, making sure you're teachable and that you're a friendly human being to work with. Like, don't be mean to your co-people. Help them out. Like, if they have a case they want to see, let them see it. And just being nice to everyone, I think goes a really long way. People appreciate that you're someone who comes in every day, is fun to work with, brings a good attitude. I think that goes a really, really long way.
Hi, so
And
sorry to
people said that
interrupt.
to me. I know, Danisha, one second. And people
Okay,
said that
sure.
to me as like a third year, and I didn't believe it. But having now been on the other side, there are a lot of people I've worked with this year that I would not want as a co-resident, and there's a lot of people who I would 100% want as a co-resident. And I think the people that I've seen who are like fun and great to work with, who are cheerful, who really have a good attitude, um, did really well this cycle. And I think it shows because they bring that attitude and uplift everyone around them. Okay, go ahead. Yes, we
Okay,
need to go
thank you.
back to the main room, correct?
No, but I was just going to say if the panelists are okay with staying a little bit over and the conversation is going well, then we could keep the rooms open and continue the conversation. If everyone's okay.
Yeah, I guess it's up to, do you want to move everyone back to the main panel and then we can just stay in the main room and people can ask us questions?
Sure. Okay. I'll do that then.
I think a few other things that I guess I'll just talk about with the application cycle. One is I think away rotations are super important. We didn't get a chance to talk about that. I would look at the WCVIS away rotation panel that we did a few months ago. It has a lot of gems in there. I think away rotations are super important. It's a way for you to interview the program and for them to interview you. And I think that that's really important, especially when you're committing 6 years to a program. The second thing that I would say is when it comes to your rank list, like really think about what matters to you. I didn't spend a lot of time thinking about my rank list until probably February. Really sit down and figure out, like, as you're going through the cycle, what are things that actually matter to you and take notes on that. I think I just took notes on a bunch of random things, but like, is clinic time important to you? Is location important to you? Is like having a female mentor important to you? Whatever it is, like sit down before you go through the application cycle and just be like, these are the things I think are important to me at this moment, and then reassess it as you get closer to your rank list.
Okay. Sounds like we had some really great discussion. I'm not sure. People were talking about different things in different rooms, so I'm not sure where we would like to pick up. But I heard Abinaya speak a little bit about things that you can do in like kind of your sub-I to really impress and or just kind of expectations as an away student. So I don't know if you want to expand on that a little bit more. I only caught the tail end, but I don't know if you Abinaya, if you wanted to speak on that a little bit more for everyone right now, then you could go ahead and do that.
I think everyone should watch the WCVIS away rotation panel. That was an excellent panel. I was not part of it, but I rewatched it and I was like, wow, like I wish I had all this information. Um, so highly, highly recommend it. It's like a 45-minute recording that we have, and it's people that like truly did incredible on their away rotations that I had other mentors tell me that like this person was really good. So we truly worked to curate that panel very strongly. So highly recommend going back and watching that. I do want to take a moment, and I feel like this is not really talked about and something I personally struggled with and would love to hear Arashleen, Hossam, and Zach kind of talk about this as well, is when it comes time to like interviewing, what are things that you're thinking about as you're going through an interview, and how did you kind of decide your rank list? I feel like that was actually so hard for me. of like figuring out beyond like my one, two, three, like how do you even compile the rank list and what were things that you thought about?
Yeah. I could talk about what I was thinking about kind of going into interviews. For me, I think I very much approached it from a place of like, I know everyone says like, you're evaluating the program just as much as they're evaluating you, but I kind of really approached it with like from a place of humility, even though I was kind of asking questions. I think there's a way to ask them, like, like how often are you going to clinic or whatever. I think kind of asking, I feel like I saw a lot of people ask questions that were maybe a little more aggressive or maybe a little more probing, and I think that kind of puts people off. And so I think, first of all, approach it with humility. And I think B, this is just like general application advice, but really think about the themes that you want to communicate through your interview. Make sure that there's always, and kind of have like 2 to 3 comfort activities to talk about, that you can kind of connect any wackadoodle question back to. And you can kind of, the name of the game is to bring any question back to something that you're comfortable about talking about, and that build your theme. So I think that's the way to crack an interview, first of all. Second of all, the questions I asked in rank list, the questions that I asked were always about how clinical the program was, whether the residents were going to clinic, how were consults taken, what does it, I think one underrated question is, what does your experience on IR look like as a DR resident? Because this is a 6-year program, you're an integrated resident, you should still have meaningful learning even when you're on your DR years. They're really your junior years, not your DR years. And so what does that look like? Because I think that totally changes your training. And so I think I was also very interested in understanding, like are is your hospital enrolling in these national landmark trials? How involved are you in landmark trials? Because that kind of also tells you the mindset that the attendings are in, and the culture of the program. Because I wanted to be somewhere where, it was very like forward-looking program where these attendings were really participating in these landmark trials and were really involved in national discourse and kind of moving the field forward. That was an environment that I wanted to train in. And so then when it came to deciding my rank list, I think there were a couple of things. I basically split the programs into 3 tiers. I think the first tier was programs that really aligned with my ideology. So a very surgically oriented, clinically oriented, kind of aggressive practice building mindset place that I was very interested in PAD. I wanted there to be at least 1 or 2 mentors that did PAD, and also like were these places enrolling in clinical trials. Within that tier, I thought about location. So that's how I kind of ranked my top tier. So it's my mom wanted me to be close to home, so I ranked a program that was close to home. But then I also had like places in Chicago and LA and like all these places also ranked very, very highly in that top tier because they aligned with my ideology. Then the next tier is like maybe like not as aligned with my ideology, and then I kind of after that also ranked based on location, and then the third tier was third tier. I dual applied IR and DR. I ranked all IR programs above DR programs. That's just I also did not get that many DR interviews, so that was really a moot point. But yeah.
Yeah, I think for me, you know, the advice that I got was to split it up also into 3 tiers. But the tiers for me were programs which I guess kind of align with yours. It's like programs that I would be happy to train there and be happy there, programs that I wouldn't mind going, and programs that I would not want to go. So for the programs that I would be happy at, I think I had like 8 or 9 programs there. And when I was trying to like self-select between all of them, I was just trying to remember back to my interview, like what was my, experience in the interview? Did I feel like I got along with like the attendings, the residents who were talking? Did I feel like, they answered my questions openly, and I feel like and that I liked the answers. Like if I asked them, how involved are residents, DR residents who are IR integrated residents, how involved are they in the IR team? And if their response was, oh, they aren't really that involved, they're like invited to come to our lectures or whatever, to me, that was like, okay, that's kind of like a knock on them. I thought about the case mix, and I think the case mix for me was really important because every single website is the exact same. Every website says that they do aortic stuff, but like, come on, let's be real. So, uh, I tried to gauge that from my away rotations, talking to people who did away rotations, or just talking to the residents. I would gauge the level of autonomy as well. Like I would ask, like an R4 or R5, like what is the most complex procedure you've done independently? So I can just gauge like, are they kind of just doing ports until their fellow year, or are they actually like doing stuff? And I think, I got a lot of varying responses to that, and I think it was really helpful to like elucidate which programs truly have autonomy. So I think it was a balance of, location. I think it was a balance of case mix. It was a balance of autonomy. And then also like I'm interested in research. Like I study computer science, so I do like a lot of like AI, large language model stuff. So I wanted to go to a place that could support me for that as well. Um, so I think when it came down to it, I sent an LOI to my number one program, which was Duke. So I sent them a letter of interest and or a letter of intent. I forget which one of the which one is the correct I, but like uh but yeah, I think that was one way to do it. And I had my mentors call them. I got a letter from Duke, so I told the chair. I got super close to this attending and this resident, and I told them, so you just gotta like mobilize your whole crew once you find your number one, and then have them like full send on this one place. So, yeah, I think past your number one and trying to decide the rankings, it's similar to how you chose your number one and just like trying to decide decide like, where they would go. And in terms of ranking DR programs, I also didn't get many straight DR interviews. I got some like, the IR DR interviews, which I guess count for DR, but I can't see IR applicants being ranked that high for those interviews. So I still ranked some, but I would imagine that if I fell in my rank list, I would probably fall past those DR programs too. Um, so yeah, it's kind of like a broad strokes, a little bit of a ramble, but yeah.
Yeah, I think I would agree. I won't spend too much time. It's very similar, but I'm sure about how we all kind of rank things. I would say prioritize definitely more than just prestige, and at the same time, prioritize where you want to go, yes, but keep in mind all the different factors, right? It's not just about, okay, great training program, because there are a lot. There's a lot of great training programs all across the country. Of course, you can stratify. There's some that are better than others, whatever it might be. But think about you as a person, an individual. Where do you want to stay and live for the next 6 to 7 years, right? Because your priorities now will not be the same priorities you have when you do eventually get into IR. Not just in terms of your clinical training, not just in terms of being a good physician, but your life outside of medicine, right? Your family, whatever might be you want to do. You have to think about all those things, and not have that regret later on when it comes down to it. So I would say make that list, really based on, for lack of a better word, your own individual preferences. Of course, there's great programs we all want to go to, whatever it might be, but think about, hey, where do I realistically want to live and build my life and whatever that might be, then stratified from down there. And I think just like Hossam and Arashleen talked about, I also dual applied IRDR, put all my DR programs at the bottom of the list, and then just really stratified all my IR stuff first. And then I even went through and stratified my DR programs. Where do I actually want to go and stay, and then strength of the IR program, whatever it might be. But really, I think prioritize your top 10, and the rest after that, generally speaking, probably statistically speaking, don't matter too much. But yeah.
Also, this probably will apply for a very small proportion of people here, but I got married like a year and a half ago. So I also had to think about like my husband and his location and like where he wanted to be for 6 years. So I think people who have a partner or significant other or spouse, like that's also something we had to put into the equation. That was really hard because I'm like, I really wanted to end up in St. Louis. Like that was like truly my number one after my rotation. And I think my husband would have actively like cried so much if we ended up in St. Louis because he hated it so much. Like every day he'd be like, I'm gonna end up in St. Louis and would like literally be so upset at the future. So we had to find a place that we could compromise on. And I think we ended up ranking it so it was like my top choice, then his top choice, my top choice, then his top choice. And I think trying to figure out what your partner also wants, because the best advice I got was that you're going to go to the hospital every day and your social community is going to be your fellow residents and your attendings. And you'll do the same thing pretty much at like most of your top 10 places with some variability. But what is your spouse going to do every day? Like, are they going to be happy? Because they're going to be the ones that experience that city and like truly live in it. So just something to also consider as you're going through the process is like sometimes it's okay to take a little hit in the program if that means that your partner or your spouse is going to have like a much better experience in that city. So he's thrilled we're going to Seattle. He got his number one. So I did not get my number one.
I did also just want to build off that. As Avi said, I mean, your social circle will kind of be your resident, your co-residents in the program and whoever's at the hospital. So I think vibes really matter, like how you felt on interview day, how the conversations went. I think everyone has their people, and it's important to try to suss that out also. I highly recommend keeping, Zach and I kind of talked about this earlier, just keeping an Excel sheet with all the details that come up during interview days. You might fall behind, that's okay. But that can also help at the very end when you're overwhelmed with how to rank XYZ towards the middle or the end of things. Looking back and seeing those notes about how you felt, who you talked to, what you talked about, and all the nitty-gritty details about each program and their, clinic days or however autonomy they say they have, helps figure that out at the end.
And just to chime in, I know like rank is one thing, but like all these principles, because right now you're deciding where you're going to do your away rotations. And that is probably, so, those are like honestly some really important decisions you're making. Not to pressure on you guys, but like think about all these things when deciding where you're going to do your away rotations, because that's where you have your best shot. That's where you have your foot in the door. So a lot of places really take their away rotator seriously. So think about these things when you're thinking about ways and like also I think a lot of like the like program reputations and stuff in IR at least like there's no like ranking or anything online the way there are for other specialties. So you only get the lowdown and like the real like opinions and how these programs are perceived in the field. Like you don't get that until you talk to other M4s that just went through the cycle or attendings. So find like one or two M4s that you can really, really bother that know everything about all the programs they interviewed at. So you can really understand what a good program is because you don't want to regret a month of money and a month of time that you spent somewhere.